All right. Good evening, everyone, and thank you for your patience. Um, and please allow us to apologize for us running late. So, for those of you who this is your first time joining, my name is Dr. Mhlangu. I am the Chief Medical Officer for Clinix Health Group. And tonight's topic will be factors that affect mental health after spinal, factors that affect psychological impact of spinal cord injuries. And that will be brought to us tonight by Dr. Mhlangu. So let me give you a brief background on Dr. Mhlangu. She's a clinical psychologist in private practice and is a consultant in various fields of mental health. In her early years, she also worked as a coordinator of the trauma clinic at Wits University. She's worked in the area of spinal cord injuries, SCIs, rehab for almost 20 years. Thank you. Her areas of she apologize. Her other areas of interest are incorporating indigenous knowledge systems in her work. She also worked on the consolidation of the reports for the Trauma, Truth and Reconciliation Commission's women's hearings. In addition, she facilitated diversity management, has worked at various companies in the area of employee wellness, and has also done competency assessments in various companies. Among numerous appointments, she was appointed to the International Rehabilitation Council on Torture in Copenhagen, Denmark, representing South Africa for 3 years. She also held the position of chairperson of the ANC branch in Washington, D.C., and was also appointed as chairperson of SANDO. Amongst her other numerous accomplishments, she holds a BA from Goshen College in Indiana, an MSc in personality psychology from Howard University, and has pursued her D.Lit and Phil degree at Rand Afrikaans University, and she's also obtained a PhD from UNISA. I'd like to welcome Dr. Mhlangu, who is an experienced and well-versed clinical psychologist, onto our platform tonight. Dr. Mhlangu, over to you. Thank you.
Thank you, Dr. Mhlangu, for welcoming me so well. And thank you for all the persons who are today gathered and are attending this webinar. I feel very honored that you took your time to come and share this evening with me. Among the sayings, the Native Americans have a saying that time is sacred. So thank you so much to all of you for taking a sacred part of who you are, which is your time, to be with me this evening. The focus of the topic has changed a bit. Initially, from the invitation, it had said depression, dealing with depression and spinal injury, but I thought that it would be more befitting to use the title, Factors That Affect Mental Health After Spinal Cord Injury. Puseleto. Slide, please. When my early years, when I came to work at the rehab, I thought that I was coming to deal with trauma because in my thinking, people with spinal injuries have gone through trauma. But I quickly realized that the trauma that they were dealing with was also almost tantamount to bereavement. They had lost something. So the initial introduction to the work was that I realized that I had to deal with people who had dealt with loss, and they were going through different stages of loss. The one stage was denial. A number of our patients, they keep thinking, because in their mind they know how to walk, but the body is not responding. So they keep thinking, no, I will walk. And even sometimes when they have to do physiotherapy and stuff, they struggle with that, because for them, it's like they can walk. Why do they need to be taught how to walk? So they go through that part of denial. And then also after that, then they experience anger. The anger sometimes is received by the carers or by the clinical team. But in essence, they're not angry at anyone else, but they're angry at their bodies, because the body now, it's not doing what it's normally used to do. And that is something that we've had to work with for ourselves, to realize that the anger may seem to be directed at us as the clinical team, but in essence, the anger is in fact coming from a space of just frustration with what was normally the norm and now is difficult to achieve. The third phase that they go through is bargaining. In my orientation in psychology, issues of faith have never been emphasized. Actually, they were never even dealt with. But having to deal with spinal cord injuries, I've had to recognize that when people are going through loss, it taps into their core of who they are, and it taps into their epistemology and their way of knowing. And most times when people's way of knowing is centered around faith, then when they go through bargaining, you'd find that they're trying to bargain with whoever the greater creator is, whether it's Allah, whether it's God or Buddha, but they go through that trying to bargain. And part of the therapy then, as a therapist, one has to help them walk that road, even though one may not necessarily be well vexed with their faith, but it is important that we allow them and to teach us what their faith is, and also how we can support them. But the bargaining becomes a very pivotal part of their journey. Then after that, people go through depression. We will talk about depression later. And also, then the last part of the cycle is acceptance. The first four are interchangeable. And then the last one, it takes time for most people. Sometimes some patients may say, no, I've accepted, but after a long while, you realize that they haven't accepted. At that moment, they thought they had, but then they experience it. For example, if they have to go home for a weekend, then they're being outside of a sheltered environment, because rehab is a very sheltered environment. Then they realize that actually what they thought was now their new norm, and then they have accepted it. It's not necessarily the case. Can we go to the next slide? So, people with spinal cord injuries mainly present with these three things. At first, I had thought that when I came into this line of work, that I'll be dealing mostly with trauma, because that was my area of focus or specialization. But I realized that now there were different things that people were struggling with. And the issue of trauma was not as paramount as the sexual dysfunction. And also that people were also presenting with depression. So to this evening, I'd like to take you through what people go through in terms of depression, post-traumatic stress, and sexual dysfunction. Next slide, please. Next slide. What is depression? And the slide before, please. Slide 3, I think it is, Buselito. No, yes, thank you. People with spinal cord injuries tend to, not all of them, but the majority, tend to present with depression. And most times they present with clinical depression. I will not read word for word in terms of the slides, but I will talk to the slides. And most of us do go through what we would call the blues or sadness, which is there's a normal experience in life. But then the difference with clinical depression is the severity and the duration. So when people tend to be feeling low for over 24 hours, that is one of the indicators they may be going into a depression. Also, with people with depression, sometimes it can be an issue of just fluctuations of mood. But if at all it's prolonged for over 14 days, then they may be clearly going through clinical depression. A lot of us patients do present with depression, but I do not want to give the impression that most of them present with clinical depression, but they do present with depression, whether it's reactive or clinical. Clinical depression affects mood, mind, body, and behavior. Research has shown that 5 to 6% of the population will develop a depressive disorder during the course of their lives, and nearly 2/3 do not get the help they require. Treatment can alleviate the symptoms in over 80% of cases. Yet because it often goes unrecognized, depression continues to cause unnecessary suffering. Even at the hospital, at the rehab, we need to, most of our patients, what their concern is the fact that they need to find their way back to being able to gain their mobility. And one has to help them to see that as much as they are dealing with their physical ailment, that also psychologically and mentally they are affected. And sometimes it's hard for the patient to see the necessity of psychological intervention when at the onset of their recovery or the onset of their rehabilitation. Next slide. Just wanted to explain on the slide what is a depressive disorder. A depressive disorder is a whole body. A depressive disorder is a whole body illness involving your body, mood, and thoughts. It affects the way you eat and sleep, the way you feel about yourself, and the way you think about things. A depressive disorder is not the same as a transient blue mood. It is not a sign of personal weakness or a condition that can be willed or wished away. People with depressive illnesses cannot merely pull themselves together. And that is important for us as healthcare providers, that we need to be cognizant that sometimes when people are depressed, it's not as easy as just saying to someone, get yourself together. Without treatment, symptoms can last for weeks, months, or even years. Appropriate treatment, however, it can help most people who suffer from depression. And even with rehabilitation, yes, we are not a mental health institution, but at the same time, we need to be able to help people with the mental health issues, especially depression, when we come to spinal cord injuries. Next slide, please. I just wanted to mention that mostly studies show that mostly when it comes to depression, men tend to go through more into manic phase and women tend to go more into a depressive phase. But it can be interchangeable. So also even with our patients, we need to help them realize that, especially with men when they're in a manic phase, that whatever the agreements they get into, businesses they get into, because some of our patients stay long and so they have to do their work while they're sitting at their bed. And so one has to always help them look at what kind of things they get themselves into, or whether it's debt or contracts and stuff, because if they're in a manic phase, that can hinder and can be problematic when they get discharged, because then they find themselves in unnecessary deaths, which they may have gotten into while they were in a manic phase. So also even for women, one of the things that we focus on at the rehab is to help them find a sense of purpose, because when people are in a depressive state, they have no sense of purpose. And when they don't have a will, then even other forms of therapy get disturbed, because then the person has no sense of, I want to do this, I want to accomplish this. They go into what we call learned helplessness. So it is very important that we also recognize how our patients are presenting with their depression, either in a manic phase or either in the depressive phase, or do they have a combination of the two? And I also need to say that, yes, in most cases, whilst with psychotherapy, we try to help them, but there have been situations, and there are situations where then medication, a pharmacological intervention is needed to help them as we journey with them. Next session. These are symptoms of depression. I would like to mention the fact that a lot of our patients struggle. I will not go through all of this, but just to mention a few, that they struggle with the whole issue of hopelessness, and pessimism. And not because they are pessimistic people by nature, but what has befallen them. It almost seems like it's something that's unattainable to come out of it. So psychotherapy is very crucial in the area of rehab, especially dealing with spinal cord injury, to help people begin to have a sense of purpose, to begin to look at life differently, that yes, they may have to navigate life differently, but they're still who they are. That has not changed. The fact that they are a parent doesn't change. The fact that they are a professional or somebody who's gifted, that doesn't change. And we try to tap into that for them to see themselves as themselves with just variations in terms of their ability. Some of our patients struggle a lot with insomnia. And part of what causes the insomnia, besides the pain, may be the overthinking, trying to make sense of what has happened. When we talk about trauma, we will talk about intrusive recalls, because also insomnia can be caused by intrusive recalls, but I'll talk more about that when we talk about trauma. Also, depression presents itself with low energy. And obviously, when they have to go through rehabilitation, they have to go through physio, OT, they need as much energy as possible. So with psychotherapy, what we then do is to motivate them. My favorite word to them is saying, and maybe some of my colleagues may find that weird, I always say to my patients, let's start walking in our mind. Even though the body is still not willing, let's start walking in our mind so that we can see ourselves going from our bed to our bathroom, from our bathroom to the kitchen. Let's continue to call upon walking. And I've taken this from the book, The Secret, where it says, for good things to come, we need to show gratitude. So by them beginning to be excited about just walking in their minds from the bed to the kitchen, they're calling upon positively. And that's the power of positive pull. And among the ways of coping, positive thinking is one of them. So one tries to inculcate all that idea of positiveness, even though maybe someone may say that's giving people false expectations. It really is not. It's giving them a sense of purpose. It's giving them a sense of saying, let's not focus on what's not working. Let's focus on what is possible. So the other thing is that people go through is the issue of substance abuse. Some of our patients, especially those who come back, maybe because of pressure sores and stuff, that they have learned to cope by using substances. And so we find that even among spinal cord injury patients, there is a notable number that have resorted to using substances to try and cope with their situation. So also the psychotherapy needs to look at not only the behavioral problem, which is the drinking, but what has caused, what is the root cause of the drinking. Can we go to the next? Also, in the past, the slide just passed, we talked about as sexual challenges and not being sexually active or excited. When also we will talk about that again when we talk about sexual dysfunctions as well. One thing that makes depression so crucial to deal with and dangerous is the fact that when people are depressed, they tend to think about suicide. They have suicidal ideations. Very rarely would they have homicidal ideations, but mostly they tend to struggle with suicidal ideation because they feel that there's no point in living. And that is the important thing where one has to help them. And I know I've mentioned the sense of purpose 3 times already, but I will keep mentioning it because that's how important it is for our patients to start beginning to realize that they do have and they should have a sense of purpose for them to be able to resume their lives as best as they can be able to resume their lives. Depression also affects relationships, whether it's significant others, it's work relationship, it's friendships, whatever relationship. Because when people are depressed, half of the time they become pessimistic, and sometimes sometimes they're not as nice. But one needs to help them to begin to resume by igniting the friendships that they have lost, by finding ways how to sustain friendships and relationships with significant others. Depression can also cause what we call generalized anxiety, where people have got psychosomatic symptoms, headaches, back pains, neck pains that are not responding to medication, and only to find that the pain is not organic in nature, it is emotional. That's why it's not responding to the treatment at hand. I hope we're still all okay as we sojourn through this. Can we go to the next slide? Another way that spinal cord injuries can affect our patients is for them to exhibit or present with post-traumatic stress. What is trauma? Again, I will not go through the slides. I will just speak to the slides. Trauma, according to the United Nations definition, is something that's outside the normal human experience. So for people to suffer spinal cord injury, whether it's through a car accident, whether it's through falling or whatever may have happened, that experience tends to be traumatic. Hence, it then people then start exhibiting certain symptoms that are consistent with trauma. Yes, most times we talk about natural disasters, detention, victimization, crime, violence as traumatic, but spinal cord injury is also traumatic because also most times it is caused by accidents, which in themselves, or gunshots, or people playing in a pool and then plunge into a pool and injure their spine. So in different ways, people are traumatized by whatever the incident is. And what I also want to mention is that we talk about post-traumatic stress, but with a lot of spinal injury persons, they deal with continuous traumatic stress because they continue to relive this life that they have to adjust. And their inability to do things, it's almost a constant reminder of what has happened to them. Having said that, I still want to stress the fact that with psychotherapy and different types of intervention throughout the rehab institution, the people are able to recollect themselves and be able to find a purpose again. Next slide, please. Also on the issue of trauma, I need to explain that when people have experienced trauma, they're trying to make sense of why this has happened to them. And working with a predominantly African community, we find that people tend then to go back to how they know the world, to either the ontology or epistemology. Then they try to think, some may think, for example, I'll just use a pseudonym. Babu Mzimela the other time said, before the scaffold fell on him, a colleague said, I'll show you. And they said it in isiZulu, ngizokubonisa. So, and unfortunately that afternoon, the scaffold fell on him. So for Ubabu Mzimela, to make sense of what has happened is that somebody's showing him something. And we cannot stand in judgment or in dispute of what Babu Mzimela thinks has happened to him. But we need to help him navigate that within the context of how he understands the world. So Babu Mzimela then comes to the rehab. And Babu Mzimela then starts saying to the nurses, he's seeing abafana bancane. Abafana bancane meaning small boys. There is no direct translation of what I'm saying. So please work with me in terms of just seeing small creatures. Maybe that's a better way to put it. And Babu Mzimela is convinced that someone has done some foul play on him. Hence, now he has lost his mobility. In terms of psychotherapy, yes, our orientation is Eurocentric, but our experience with our patients needs to also look at indigenous knowledges, needs to look at Afrocentrism, needs to look at, if we're dealing with an Indian patient, we may not know much about being Hindu, but we can learn from the patient to understand how they understand their world and what has happened to them. So I was using just Babu Mzimela just to give an example that also psychotherapy needs to be contextual. We need to reach our patient where they are at so that this whole talking cure makes more sense to them. Because if we don't do that, psychotherapy becomes abstract for most persons because that's not their way of viewing the world. Can we go to the next slide, please? Now, the symptoms, again, I won't go through all of them. But what we also see with trauma is that people, as I've spoken about insomnia, that sometimes they don't sleep because they're preoccupied with thinking about what has happened. Sometimes it may be because when they close their eyes, they see a movie of things that they do not want to see, of what had happened to them. So it can be intrusive recalls, what we call intrusive recalls. And intrusive recalls are nightmares or flashbacks. So some people who have gone through trauma, are spinal injury patients, may be experiencing nightmares, which are nighttime movies, or flashbacks, which are daytime movies. So it is important that we also help them to work through those and make sense of what may be the dreams. Not that one is trying to say I cannot interpret dreams, but I try to help the patient look and understand the dream within the context of what has happened. And also to help the patient not to think now that they're losing their mind. Why it is also important that we help them with the intrusive recalls, because if that's not attended to, patients may experience what we call dissociative experiences, which is very rare, but they can. And dissociative experience then become a mental health issue or illness. Most of our patients tend to have startle responses. If we take Dr. Mzimela, for example, a scaffold fell on him, so something fell. So anytime they hear a falling sound or a banging sound, they startle. And in the ward, it's important sometimes to help the nursing team to realize that the patient is struggling with startle responses so that they're cognizant to ensure that as best as possible, there's little as banging or falling sounds. Or even when they wake up the patient, to know whether, because trauma, can I just jump to say, trauma affects our 5 senses. So sometimes some of our patients, you may find that the sense that was affected is the audio sense, hence they're sensitive to certain sounds. Or it's the touch. If it's touch, if they were being woken up and somebody touches them, they may startle. So it's important that as we work as a team, then we help the other team members know as to how to navigate a certain patient based on the symptoms that they are showing. Trauma can also affect one's memory or concentration as well. And how I normally explain that is that if you take an electrical gadgets in your house and you put them on, you switch them on, there will be 2 responses. If the circuit is heavily burdened, it will switch off, it will trip, and that is the forgetfulness. If at all it's not too heavily burdened, the light will flicker, and that is lack of concentration. So how we explain to our patients is that now that, because then they start thinking, am I losing my mind? What has happened to me? I've been able to remember things. All of a sudden, I can't remember. Then one helps them with that analogy to realize that no, right now, your circuit or your electrical circuit is heavily burdened. That's why there are these lapses in terms of remembering things. One tries to be as practical and using as tangible examples as possible, because we all do know that there is a lot of stigma around mental illness. So when someone experiences anything that can connote mental illness, they go through anxiety, or because they don't want to be associated with the stigma of mental illness. So it is important that psychotherapy plays a role in helping people be able to understand within the context of what's happening and not to exaggerate what may be happening to them. Can we go to the next slide? Next slide, please. We spoke about depression. Trauma can cause depression as well. Irritability. When I started, I spoke about anger, that some of our patients exhibit with irritability or even sometimes episodes of rage. That's part of that anger exhibiting itself. Some of our patients exhibit what we call blunted affect, and that's a fear of trusting or a fear of loving. So sometimes in the ward, you may have a patient who just has trust issues, and we then try to help the team and the patient to work around the trust issues and understand where the patient is coming from, because maybe whatever happened to them, somebody betrayed them, and hence they ended up in the situation that they're in. As I said, I will not go line by line, but please, when question time comes and you would like to ask a question on things that I may have skipped through, please do so. I'll be willing to go back and explain whatever you would like for me to explain. When I was talking about the flashbacks, and sometimes for some patients, you find them very weepy. Obviously, it goes with being depressed, but also when they relive what they went through, they may find themselves unable to speak. Sometimes they choke, sometimes they're very weepy. So, and with psychotherapy, one tries to help them, not to say it's okay, this has happened, but for them to find a way to amalgamate what has happened with where they are at and where they would wish to go. Next slide, please. The third thing I mentioned was sexual dysfunction. Most of the patients, especially male patients, if their injuries is below T11, they start having sexual dysfunctions, most times erectile dysfunctions. and ejaculation issues and impotency sometimes. Most of our patients, as I mentioned earlier on, you find that the issue of the trauma is secondary. The primary issue is the fact that they cannot get an erection. And the focus and the preoccupation and the fears that will their relationships sustain these injuries, because now there is no sexual abilities. We hasten to help our patients, especially, again, I keep saying male patients, because I'm not sure, I do not want to exaggerate to say it seems like most of our male patients, I know their manhood is measured by their performance in bed, but it almost seems like that because it becomes a preoccupation. And even amongst themselves, they talk a lot about that I find that as I walk the corridors, a patient will come to me and say, and saying, I've heard that you are the one who fixes people's relationship. And I know already they're talking about sexual dysfunctions. And I find it very interesting that in my own stereotypical way of thinking that where as African people, especially my age, we don't really talk about sexual matters. But I find blue-collar workers, mine workers, coming and asking me, can we talk about fixing my house? The resistance I find from the female, not patients, but spouses, that they feel very uncomfortable when I start delving into the sexual matters with them and their spouses. So that has also been a learning curve for me as to what language, what type of language does one use so that it almost makes someone feel comfortable. For example, I have had to find out that it would not be right for me to use English words like penis when I deal with an African man. I need to find words like indugu, ibande, whatever it is that it's acceptable to the person. With the sexual dysfunction, people, they worry about whether, again, I've mentioned, the relationships will sustain or their marriages will be able to withstand the challenges. They worry, again, about whether they will have children or not. They also worry about when they are sexually active, how will they know if they reach an orgasm? Because then from waist down, they cannot feel. So those are things that we also cover when we do sexual counseling. There are challenges about if they have an inbuilt catheter with them, how do they become sexually active? So one has to help them know how to do that. Others, those that who just catheterize, may have the problem that, what if I have an accident? And it's a whole area of help, of field where there's a lot to be learned, there's a lot to be understood, that we help our patients. So with psychotherapy, I need to acknowledge that the sexual counseling aspect, it's a specialized area that not all of, even for me, before I came to work in the area of in rehab, I did not know about that. So I have had to learn over the years how to help people with sexual dysfunctions. We help them from arousal point because now the focus was from waist down, and now the focus needs to be from waist up. So they need to find new arousal points. So we help our patients discover the arousal point with their spouses. We also help them with things that can help them with an erection. And so there are three things that we normally suggest. One is the obvious one, the tablets, example, Viagra, but that one is unattainable for most of our patients because it's very expensive. So even if part of their medication and Tito, there is the Viagra, but it's only 4 tablets. So what happens during the course of the entire time that while they're still waiting for the next for the delivery of their medication. So We encourage them that you can use a medication tablet if you wish to, but there's something else that's more lasting and that you buy once off. But I'll come to that something. The second thing is the injection prostate. Right now, it seems like there's a debate about its validity, its usage, and its safety, but I will just mention it because that's something we've had mentioned over the years. However, the problem with that one is that it needs to be kept in the fridge. And we do know that this is the age of Googling. Everybody, when they see something in the fridge, they will Google. So somehow the patient's secret then becomes common knowledge, and sometimes some family members can even put the patient down or say things that are nasty to the patient. The third one is the vacuum erect pump. The vacuum erect pump is an instrument that literally looks like a pump. But it's very effective. And most of our patients have really found it helpful. It takes getting used to finding the right the right size in terms of I've forgotten the thing that they use to get the right size and to know how to use it, how to use the different for example, the lubrication and all of that. But those are things that with psychotherapy, we help our patient deal with. And to help, especially in this area, help our patient to regain their sense of dignity and their self-esteem. So these are things coming to the conclusion. In terms of spinal cord injuries, just summarizing, our patients struggle with a lot of things, including mental health issues, such as depression, post-traumatic stress, or continuous traumatic stress, plus sexual dysfunctions. What is also very important is the fact that as we deal with different population groups, we need to also learn how to appropriately, especially when it comes to issues of sexual dysfunction, how to appropriately use language in a way that it will not put them down, it will not disrespect them, but it will help them to also see that there is life after spinal cord injury. What I also forgot to mention that part of that chain of sexual dysfunction is teaching people the different positions that they can use when they are intimate. And it's very interesting to see that. And most of the patients, when you ask them, did you know this? They didn't know this position. They only knew one position or two positions. And so then they get excited to realize that there's a completely different world that's opening up to them. And in that way, they start having a sense of hope and a sense of, even if I'm in this situation, life continues to go on and I can go on and sojourn my life with dignity. That brings us to the conclusion of tonight's presentation. I'm open to questions.
Wow. I thank you so very much, Dr. Mhlangu, for that. That was very powerful and a very interesting talk today. I must say that with so many different cultures within South Africa, I think sometimes we tend to forget that we must actually meet the patients where they are and not always speak English or medical jargon, but we need to be able to get our points across, the diagnosis across, the treatment plans across in a way that our patients understand, and that it's not just informed consent, but they too become part and parcel of that treatment plan. I think sometimes as healthcare professionals, we tend to have a paternalistic view of when we treat our patients instead of bringing them into the management plan. And this was very well presented. I must say that though, sexual dysfunction is something that we always tend to forget about. I think we're more concerned about getting our patients back into their activities of daily living, forgetting that intimacy is an activity of daily living. It might not be daily for some people, but it is considered an activity of daily living. And I must say that was very fascinating, and I think that's something that we also need to take back. So I have one question from my side before I start getting the questions across. In terms of what you talked about, the neurological system being overburdened or overstimulated, and you led that back to certain, that could also manifest itself in psychosomatic manifestations. Would that also then affect your sexual dysfunction or sexual health?
Yes, yes, it can. But now, for mostly the spinal cord injury patient, it's looking at the physicalness, the fact that I can't feel when there's an orgasm, I can't do this. So the preoccupation is about the physical inability rather than the emotional impact that causes you not to perform.
Okay. So we've got a question here from Muhaddin Khan. It says, if the patient is paraplegic, then question is, do patients not agonize more, especially at the loss of the sexual function, especially if they are led to believe that VP and that they may eventually return to relative normality? So do you find that there is some type of, Dr. Khan, you'll tell me, you'll correct me if I'm wrong, that maybe patients get this disappointment at assuming that they will have some return to normality? Dr. Mhlangu?